Welcome back to Health Law Pulse, the podcast where healthcare, leadership, and law intersect, and where we focus on how healthcare actually works in practice. I'm your host, Jonathan Rhodes, healthcare attorney and founder of Health Law Counsel, LLC. My guest today is Dr. Scott Kronlund, a physician, executive leader, and consultant who has spent decades working alongside healthcare organizations as they navigate growth, governance, and system-level change. Scott has served as a physician leader with integrated networks and has advised healthcare organizations across the country on strategic planning, leadership development, clinical integration, and physician alignment. What makes Scott's perspective especially valuable is that he brings clinical credibility into rooms where strategy, compliance, and operations all collide. He understands what it takes to lead physicians, build trust, and move organizations forward in an environment shaped by regulation, payer pressure, and evolving care models. In this episode, we talk about physician leadership, independent practice models, clinically integrated networks, value-based care, and how thoughtful governance and alignment can help organizations manage risk while staying focused on patient care. This isn't theory. It's not a compliance lecture. It's a practical conversation about leadership, structure, and decision-making in today's healthcare landscape. This is Health Law Pulse. Scott, thank you for joining me today on Health Law Pulse. Really appreciate your time. I know you've got a lot going on, and I was very excited that you had accepted my invitation to come here and talk to me, just because of your great background, your vast experience in some of the topics we'll be discussing today. So thank you very much for chatting.
Yeah, well, you're very welcome, and thanks for inviting me. I feel very honored to be joining your new venture here.
All right. Well, I appreciate it. And Scott, what I like to always start with is we'll get into some substantive questions here shortly, but I really like to hear what got you into medicine. You went through this transition of practicing medicine and then went into the leadership routes, physician executive routes, and operational leader route. And so what got you into medicine? What caused you to make that transition? And if you just give us a brief summary of your journey,
Sure.
that would be great.
Oh, wow. My journey goes back a long ways till to my ninth grade year in junior high school.
Okay.
Um, I just like tell people I'm a second generation immigrant kid. You know, my family we're not from a long history of academics and
Mhm.
whatever. But I had a health teacher who along the way showed some video movies. They were movies at the time, but
Yeah.
showed videos of some biomedical engineers
Okay.
that were actually designing some of the first functional artificial limbs for people who suffered amputations and the like. And that was just totally fascinating me, given my interest in math and science and
Mhm.
everything. I just thought this was really cool. They were taking people who really were unable to walk and had been unable to walk for a long time, and now making it possible for them to walk. And I thought, well, that is really cool, and that's really a great contribution to society and to those people in particular and their families.
Right.
So with that in mind, just found myself thinking about that a fair amount and decided, what the heck, I might as well just, go all the way and head off into medicine. I had a really great primary care doctor who had taken care of me for years. I liked him a lot. He was a good, mentor and role model. So I put my blinders on, and that's what I did.
Mm.
Through my high school and college years, everything was geared towards getting to medical school, which ultimately happened. I went to the University of Washington in Seattle, and I've always loved primary care, so that got me into primary care residency, you know, um, in at the University of Iowa, and then back home to the Seattle Tacoma area where I had, grown up and started my practice. And along the way, I found myself involved in a lot of leadership things as part of the medical staff.
Right.
This is kind of before the era of so many employed physicians. So I was,
Mhm.
the chair of this committee and the chair of that committee and the like, and just naturally drifted into these sort of leadership areas while I was also building my practice. And then in 1990, February of 1992, I went to a conference, happened to be in Hawaii. It's a good place to go in February, put on by the Estes Parks Institute. And this was in the wake of Bill Clinton talking about managed competition
Yeah.
as the new model of healthcare in America. And so I went to this conference and I was just totally blown away. I had never thought
Mhm.
about healthcare from a macro perspective, from an
Right.
economics perspective, from a policy perspective. And a friend of mine at the hospital, who was one of the VPs there, actually signed me up to be a member, become a member of an organization then called the American College of Physician Executives,
Okay.
which I'd never heard of. So I started getting correspondence from them. I learned about their master's program in preventive medicine and admin med at the University of Wisconsin. So the next thing you know, I'm heading off to graduate school
Hmm.
because I really wanted to pursue this. I wanted to have, I think, really at my altruistic side, wanted to have more impact in the community than I could have just in my own individual practice.
Sure.
And so, with that master's degree and the fact that managed care was just showing up in the early to mid 90s, I slipped into a role of a medical director because we were starting our full risk bearing
Hmm.
physician hospital organization, which was a wild and crazy idea and a wild and crazy ride
Right.
uh, that lasted till about 2001 when managed care left the scene in Washington State.
Okay.
But that's kind of what launched me in that direction, and never looked back.
Wow. Wow, that's quite a journey. It's interesting to me, Scott, that whenever I ask people, regardless if they go into medicine or whatever it is, it's typically something that happens around that age, right? The seventh, eighth,
Right.
ninth, 10th grade, that somehow informs how they are going to spend the rest of their life and what they plan on doing. It was it was something similar with my brother. I interviewed him for the first episode.
Mhm.
It was something similar, and he actually started going into architecture and realized that's not for me. So, but it's somewhere along the line there. It sort of clicks on what they want to do. That's fantastic. I appreciate you sharing that with
A
us.
magical epiphany or something. I
Yeah,
don't know. I don't know
yeah.
what, but here I am, more than 50 years later, still schlepping around in all of this.
Still at it. That's great. That's great. Well, thanks for sharing that. And I do want to get into a number of topics and certainly covering the experience that you have and you talked about how you were sort of on the forefront of managed care in Washington and I want to talk a little bit about that. But one of the things, Scott, just to start off, one of the things I see consistently in my practice is how much strain our healthcare system puts on leaders who, like you, are asked to think clinically and then also asked to think operationally at the same time. And from a legal and governance perspective, many of the biggest failures I deal with don't necessarily stem from bad intent. And nothing nefarious is going on. They stem from misalignment. Really misalignment between clinical reality and this system level decision making that can obviously lead to operational and compliance failures. And you've lived both sides of that equation over here practicing medicine while also holding executive and advisory roles. So I'd like to start there with my first
Okay.
question. How has continuing to practice medicine shaped the way you think about organizational strategy and really leadership decisions at the system level? You practiced primary care for quite
Mhm.
some time before you started down that different route. How has that informed the way you think about sort of that strategic leadership
Sure.
role?
I don't know how. Yeah, it was fairly strategic, I think, in my thinking. I thought I cut my. That's where you cut your teeth, right? You get a
Right.
bird's eye view of what people in the trenches have to deal with. You've got to. There's so much. There's a lot of dysfunction and maladaptation and stuff that happens in a clinic, and there's a lot of can be a lot of chaos in there. And as a result, plus when you think about all the demands, especially in today's world, right? So we have demands around patient care, we have demands around population health. We're supposed to coordinate care to the best of our ability, deal with metrics, all of these kinds of things. You can
Right.
certainly see why people just get burned out.
Right.
And I really think that you appreciate that, when you're part of it. And that wasn't anything I was really looking for when I started in practice. It just happened. I
Yeah.
saw what life was like for my 5 partners, in our group at that time, and what it was like for our team and for our staff and whatnot, and found myself just naturally uncovering opportunities to improve things.
Yeah.
And some of my partners thought I was crazy. Like, why would I even bother? The better part of valor is just put your head down and go to work, and don't let these things get to you. Why in the world would you want to improve them? Well, I was a little short-sighted, I thought.
Yeah.
But nonetheless, that's what I started doing, and they didn't get in my way. That was the good news. I started changing all kinds of workflows and things in the office, and I think in many ways they benefited from some of those changes, even if I'm not
Sure.
sure they ever really uh,
They still thought
acknowledged that.
they still thought you were crazy, huh?
They still thought I was crazy. Yep. There's always, I've always been a person that there's always a better mousetrap that can be built, right?
Sure.
We just have to take the time to do it.
Absolutely. So that's interesting, and it makes a lot of sense to me, right? You spent all those years on the front lines, both from a clinical approach, patient care, quality, safety, even reimbursement perspective, and you bring that into network leadership. So what do you think so if I'm a practicing physician, I'm interested in getting into network leadership, what would your advice be to me? What's the biggest learning for clinicians who want to transition into that sort of leadership role?
Sure. I think the biggest transition I think I had to make, and I think we all have to make, is from, and I'm going to coin a phrase here from a famous author here, but the notion of making the shift from being a soloist to a conductor.
Mm,
That's actually a quote from John Maxwell. He's
okay.
one of, he's an international guru of leadership,
Right.
and he wrote a book called Leader Shift. And he talks about these 13 shifts he had to make from being, a solo actor into becoming an organizational leader. Because I think, especially for physicians, you think about this, John, when you show up in a clinic with a medical degree after your name, you're suddenly at the top of the pyramid.
Right.
Whether you deserve it, whether you've earned it, whether you're capable, but nonetheless, you are the person. And in most cases, all of the support functions are designed around your need for efficiency, effectiveness, seeing the right number of patients, et cetera, et cetera.
Right.
Um, and so you just tell people what to do, or you just write a prescription, or you know what I mean, or you
Right.
do what you just sort of call it out. So even though I had a graduate degree and I was, which and we can talk for a minute here about the potential value of formal education
Hmm.
to support this kind of transition. But nonetheless, even after graduate school, I showed up, I was working at the hospital, and I was just calling shots. I had a great idea. Let's just do it. And I really was very naive in realizing that no, that leadership really is about influence, and the folks you have to influence within a complex organization to make a change,
Hmm.
is complex. It's a complex activity. You don't just show up and start telling people what to do, because they'll turn around and tell you why they're not going to do what it is you think they should do.
Yeah.
So I think you have to learn how to work. Plus, there are all sorts of other systems and things in place that are totally new, compared to what it's like working in a clinical practice. But I think the pathway starts. I think the pathway though starts with, what can you do on an informal basis?
Hmm.
Are there work groups? Are there committees? Are there places where you can go and kind of cut your teeth and learn how the environment works around you, and then consider how and when, any, advanced education might be of value to you as well.
Yeah, Scott, I love that conductor analogy because I've talked about this before, where you're right. You have you take your leadership team at a group or a health system, and you have folks from all different service lines. You have folks from different support areas, right? You have compliance, you have legal, you have clinical, patient safety, revenue management, whatever the case may be, all have their own interests in mind, but also the health system's interests in mind. But at the
Mhm.
same time, sometimes those interests compete with each other, and there's some tension there. So your thought about you really got, I mean, as part of leadership and being a conductor and you having the experience of that frontline patient care, or any physician executive is really important. What do you think? You talk a little bit about sort of the formal education and making that transition, which I can absolutely see the value of. The other piece to that, what do you think that the clinical credibility or your clinical acumen affects? How does that affect your ability to lead system level change?
Sure. Well, it's interesting. I guesstimate that somewhere in my full-time clinical world time, I probably had 50 to 60,000 individual, you know, and patient engagements,
Oh wow.
which I thought gave me a pretty good feel. Seen a big variety of things,
Right.
had to deal with a whole variety of situations. But it's interesting, John. I don't. That's a good question because I don't. I don't think I was ever asked along the way, no matter where I've been in my career. Nobody's asked me how many patients did I see. What I think happens as a result of that, it just comes out of you. It's in your language. It's in your confidence. It's in how you smile and nod,
Right.
with people around and endorsing their, experiences. And you really don't have to flaunt it or anything. Somehow it just sort of magically kind of happens because you've been there.
Right.
And
Right.
and actually, I get concerned about young physicians who are jumping right out of their medical training and heading off into their, business training
Hmm.
at the end of the day without really stopping in between to
Mhm.
really gain some boots on the ground experience. I mean, that's my personal bias,
Sure.
and I think there's a lot of really smart people out there, but I think you got to get some street cred. And I don't think residency training, no matter how much clinical experience you have in residency, is a substitute of being out there making decisions on your own.
Hmm.
Because what I found with other physicians, other more seasoned physicians, I was respected because number one, we've had the same training experience, right? Maybe in a different location, but we all kind of get the deal. We've all been to medical school. We've all done the residency thing.
Right.
But sometimes I would have to mention that I'd been in practice, but most of the time I never did. Because I really do think it was just part of how I came across to them, whether it was intentional on my part, or not. It kind of just happened.
Right. Right. Oh, very interesting. Very interesting. So, Scott, I kind of want to shift a little bit. This has been a great discussion thus far to independent physician associations, and I spent a lot of time, or IPAs,
Mhm.
not the kind that you drink, but the other kind. So I spent a lot of time advising independent physicians, and they feel like they're caught in between two extremes. One hand, there's a desire for total independence. The other hand, there's increasing regulatory burden and there's this desire for just practice medicine and have the full employment, but with that there's to a certain extent a loss of autonomy. And so IPAs, I think, often get positioned as a middle ground. And I know that anytime you put the words independent physicians and standardization in a sentence, there's a good story coming. I'm sure you have several of those. But but from where I sit, IPAs today feel, and you tell me if you feel differently, but they feel very differently than they did even a decade ago, maybe 10, 15 years ago. And not just in scale, but sophistication and regulatory expectations. And you were deeply involved in growing Northwest Physician Network, which was an IPA. So you've seen this evolution firsthand. In fact, you helped grow NPN during a period when IPAs were becoming far more sophisticated from a compliance standpoint and a contracting standpoint. So I guess my question is, what opportunities do IPAs offer physicians today that maybe didn't exist 10, 15 years ago? How's it changed in the
Sure.
last decade and a half?
Yeah. Well, let me start with a couple of little philosophy about, IPAs and practices. Yes, we wanted our physicians to focus on being the best physicians they could be.
Right.
And ultimately, we grew beyond physicians to have nurse practitioners and PAs and lots of other, medical clinicians who were part of our deal. But what I really learned along the way with all of the demands around quality measurement, population health, care coordination, all these things that are part of the marketplace today are the things that really either confuse or put a lot of burden on practicing physicians, particularly in primary care, who want to focus on patients.
Hmm.
Because after all, we were trained in disease care. We may call it healthcare, and certainly we all, I think, as a primary care provider, I certainly tip my hat to the whole idea of wellness
Right.
and population health. I wanted my patients to get their cancer screenings at the appropriate time, or their immunizations or whatever it may be. But what I discovered along the way, and I got that good traction around this with our providers, that I started differentiating provider work from provider endorsed work.
Hmm.
In the sense of, so what are the only, what, as a medical provider, what are the things only you can do? Whether that's from training, experience, licensure,
Right.
whatever it may be. There's certain things that require, a clinical degree, clinical license, et cetera. And certainly a large amount of responsibility that goes along with that, around making actual clinical decisions, on behalf of your patients.
Right.
And then there's other stuff called physician endorsed work, because we would all nod our heads that, yeah, we want our patients to get their cancer screening. We want them to get well, like I mentioned. We want them to get their immunizations or whatever it may be. But what I learned was that second piece was the part that was burning people out.
Okay.
And if you're in a small private practice, you don't have the financial resources to be able to do all that easily, right?
Right.
And back in the day, I mean, we were doing stuff with Microsoft Access and Windows 97 environment.
Right.
We had to bootstrap stuff together, because that's as good as it got in the day. So move the clock forward. Now we have an IPA serving as what I would call an aggregator.
Okay.
So we, as an aggregator at NPN, we were able to help build all of those support systems to try to remove as much of that physician endorsed work off the backs of the providers. And so
Okay.
so that means if I have a list of all of your patients under contract with us who are between the ages of X and Y and of a
Hmm.
specific gender, why don't you let my team call those people and see if we can't get them scheduled for their fill in the blank. Or let me work with your team at your office if that's how you would like to do it. So together we can contact these patients on your behalf. And all I need from you as a provider is the ability to bring those stubborn patients in front of you, so you can help intervene. And so that led us down this whole trail of, pursuing, clinical integration, however one wants to define it, since the FTC seems to have variable thoughts on this.
Right.
But that's what we started doing. We started becoming, as we started developing these support systems for our providers, to take some of that burden off of them. That led us right down the whole trail of clinical integration, where we could start seeing ourselves, aha, if we could build enough supportive infrastructure around care management, complex case management, we did our own credentialing, we paid our own claims, we did all kinds of things, as part of our payer contracts. And if we could get everybody functioning, and we built a referral management system that was agnostic to medical records and other
Hmm.
kinds of things like that, that we actually could come together and present ourselves in the marketplace as a pretty solid organization. So we had, 1,200 providers, 60 different specialties, a whole host of ambulatory diagnostic and treatment facilities that were in our part of our network. That's a pretty, and we could go to a health plan and say, look, and we can provide this geography, we can provide this level of access to you. We found out this became a really powerful model. So we were able to bring contracts to our providers that were far better than they could most of them could get on their own.
Right.
And we had all of this other support, and support services so that they could focus on taking care of patients. And all I asked of them is when the phone rang and somebody from our team needed something from them or their team, that we would get first dibs on the telephone tree.
Right.
Because we weren't there to waste your time. We were there to actually help support you. Because at the end of the day, if you really like the private practice model, you also have to realize you've got a business to run.
Right.
And so why don't you focus on taking care of patients? Why don't you focus on running a healthy business, right, as a business entity?
Mm-hmm.
And we, the IPA, in exchange for your participation with us in these contracts, will try to get you a better deal than you can get on your own. And we're going to support you with all of these tools and technology. So now when you look at these, you look at these large EMR systems, the big name, I won't use any names, but, the big ones that
Sure.
have population health support and clinic, and everything. You go, wow, this is really something. And if an IPA can be the conduit for that. So I worked after my MPN time. I actually went over to the Big Island of Hawaii and worked with a small IPA of about 50 or 60 providers over there.
Okay.
But we had staff in the office who, on a shared EMR, in our office, who were calling patients and scheduling them, on behalf of participating physicians, so they could see
Right.
it all because it was all on the same, it was all operating on the same system.
Hmm.
And that was really cool too. So when I think about the advancement of technology, and if an IPA can get the resources required to deploy those things, wow, now you really have some good glue, along with pretty sophisticated nursing and social work care management support. As a network, you can do a lot of really good work.
Yeah, that's really interesting. So I'm just trying to summarize what you just said into some bullet points in terms of the way that perhaps IPAs have shifted over the last couple of decades, or what additional opportunities they provide. Certainly, largely driven by technology, as you mentioned. That we're not dealing in access database for well, maybe we are. So maybe some are. I don't know. But there are certainly better technology tools that allow an IPA to provide better support services to contracted provider groups.
Mhm.
And with the increased emphasis on preventative care and wellness certainly over the last 20 years, that's become more of a necessity. To your point, to avoid physician burnout, they could focus on what they do, and to broaden maybe the IPA into multiple different specialties, as you mentioned, social work, case management, things like that, to really get a great clinically integrated uh, 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 sort of system that allows for great patient care. Is that sound right?
Yeah, I think so.
Okay.
Um, yeah, because I think there's a bit of a, your brother mentioned this actually when you were chatting with him about the notion of, how interested are primary care doctors in all of this other stuff.
Right.
And his answer was, well, like quality metrics and whatever. It's like, well, not really, or maybe a little bit or whatever. But, the paradox is that even though that's where the providers' heads may be, the marketplace demands, especially, speaking of the payer environment,
Mhm.
they're all over that stuff.
Right.
Medicare, Medicaid, the commercial carriers, this is how they compete. They compete on because it's the thing they can measure.
Right.
And so the question is, if you want to remain relevant in the marketplace, the fact of that is you need to figure out how to meet these requirements. And I think having an IPA like structure to step in and lead the charge on that is a real value, very valuable, way of thinking about things.
Sure. And Scott, I don't know the answer to this. But I'm curious your thoughts. and maybe there's no impact at all, but do you think there's been any impact on how IPAs are not structured, but how they function with the increased independent practice of uh, PAs and NPs? Has that had any impact on IPAs at all?
I can't speak for IPAs at large, but we in our organization, especially if they were working in a primary care setting,
Mm-hmm.
we allowed them to carry, to have panels of patients.
Mm-hmm.
And we treated them just like any other primary care provider, because when you think about it from a couple perspectives. Number one, we have a shortage of primary care
Right.
providers, and number two, your ability to engage a health plan has a lot to do with your capacity to take on patients at the primary care level.
Sure.
I mean, it's great that you've got wonderful surgeons and medical specialists, and you have all those things to back you up. But at the end of the day, it's about that tight connection of patient to primary care.
Right.
And so trying to create as much capacity as we could in the primary care space was a really was a prime objective.
Sure. Sure. That makes sense. And when IPAs, we talked a little bit about clinical integration. When IPAs start moving towards clinical integration, they start getting into value-based arrangements. The legal posture changes dramatically. Suddenly, we're talking about governance. We're talking about antitrust. We're talking about payer contracting, quality metrics, which you just mentioned. Real compliance infrastructure is needed, not just some sort of loose affiliation. And clinically integrated networks, or CINs, CINs, for those that don't know, not the other CIN, SIN, but CIN.
Right, whatever you want to call them.
CINs, they sit right at the intersection of clinical strategy and regulatory risk. And many organizations, I think, underestimate that complexity going in. I've heard many times, "Hey, I want to form a SIN." Well, okay. I mean, there's a lot that goes into that. We're not just forming a SIN and having at it tomorrow, but so it gets to be very complex. How do you see IPAs and SIN models intersecting with, for example, accountable care organizations or ACOs, and really broader value-based care strategies?
We can talk for a long time
This will be a
that.
four-parter.
Oh no, yeah. A couple things I guess I would say at first blush is I found out, for example, when I went and talked about those kinds of things with the providers,
Mm-hmm.
most of them just gave me a blank stare
Sure.
or patted me on the head and say, "Thanks for coming, Scott. Like to talk to you." Even one of my former clinic mates who one day said to me, "Scott," he said, "I don't have a clue what you're talking about, and I've got a patient to go see," and off he went. Right?
More physicians thinking you're crazy. Is that what it is?
That's right. So yeah, I think in our case it started at the top, and we weren't that big of an organization. It really started with me. I mean, this is where my two things. Number one, I would say my formal education really came into being,
Sure.
because I had sort of an integrated master's degree. Wasn't just MBA. It was included things like health law and the like.
Right.
And so I had a basis for thinking about that. But I also was able to team up, with one of the most seasoned healthcare attorneys in our region.
Right. Right.
And we had at least I had made a decision that we weren't just going to have, our contracted lawyer. We're going to try to minimize his bill, and we're going to not have him do a whole lot. We actually brought him in at the strategic level, to be able to say, "Look, this is kind of where we think we need to go. You understand better than we do about how the feds are thinking about things like clinical integration,
Yeah.
and here's where we want to go. And so let's not do compliance after the fact. Let's just do our design work, from the beginning with compliance in mind. Compliance is not going to go away. You can't just put your head in the sand. There are things to be concerned about, whether it's antitrust or any kickback or
Right.
Stark or any number of, kind of the standard menu. But let's just do this together. And we did a lot of this stuff behind the scenes, because I remember when IPAs first started, it was like, aha, now's our chance. We can take back, we can take back healthcare. All we have to do is, band together and we can tell those payers where to get off and blah, blah, blah. And I remember all of those, the grandiosity. And I think the
Right.
CIN temptation is kind of in that same, that same vein.
Right.
But I had a good coaching. I had to go learn. I read all of the tri-state correspondence from 2006 and the famous Christie Braun letter and
Mm.
all these things that are fairly, that are conversational to you guys in healthcare law. But I really had to dive in and do a deep dive to say, okay, so what is this about? And now we've developed a framework by which we can now compare all of our, all of the things we were designing inside the building.
Okay.
And how does our quality team, our quality committee actually function? How does our credentialing system actually function? Do we have the ability to discipline, patient, physician providers?
Hmm.
Do we have a means of corrective action? Do we have a means of expelling people? If they're not living up to the standards that we set. And then what I did was I tried to distill those key elements down to the vital few and hit the road.
Okay.
Lots of meetings, lots of physician meetings,
Sure.
group meetings, lunch meetings, cups of coffee, a lot of shoe leather, a lot of tire rubber,
Right.
uh, carrying the message one by one, and trying to bring people into alignment that at least would say, "Yes, I understand this is important. I don't agree with it, but if the IPA can do this for me, I'm all in."
Sure.
And that was really all I needed,
Right.
to be able to move forward.
Right. So one thing that I just want to call out that you said, which I absolutely love, and I preached this a number of times, bringing legal or compliance in at the strategic level as you are thinking about how do you form this sin, or and really it's not limited to sins, right? It's any venture, any healthcare venture, any business venture, because it helps. I think it's more efficient. It helps form that path, or help the other people in that work group think about what is the most efficient, right way to create what we're trying to create within the right framework, as opposed to after the fact, here's what we created. What do you think? And and then sort of going back and retooling things. And so I love that. I think that's hopefully the bill wasn't too big, but I love the fact that that
Yeah,
that you did that, because I think that is, it seems
right.
like you would agree with that is just a far better approach in handling these sort of arrangements and ventures.
Well, here's what I ultimately thought about that. The fees are the fees are the fees, and they are what they are, right? We all work for a living, but the real point was that I always wanted to engage the attorney on the front end that I was going to ask to defend me on the back end.
Sure.
And the fact of the matter is, we almost never had to defend ourselves on the back end because we thought about it. But even think about things like physician incentive programs,
Right.
especially when you're dealing with federal contracts, because most of our contracts were in the Medicare Advantage and Medicaid world.
Yep.
People get concerned about what are you incentivizing and how do those work? And, that's just one example of where you really want to have, some learned partners, going down the road with you. So
Yeah.
anyway,
Yeah. Yeah. Well, it
that's
adds
my
a
that's my
yeah.
commercial for your practice.
Yeah, well, I appreciate that. It adds an entirely different layer, and not if not multiple layers of complexity to it. You mentioned the physician incentive piece, which is a really great example of that. How that really just adds a lot of complexity to the arrangement. Just briefly on that point, in your experience, what's worked best? I'm just thinking physician engagement or APP engagement. What's worked best to maintain that engagement while meeting? I mean, obviously the sin has clinical goals, the sin has financial goals. What has worked best, or what's the first thing that comes to mind when you think of physician engagement and trying to achieve both of those goals?
Um, First of all, I go back to the very thing we talked about a long time ago about the notion about provider work and provider endorsed work.
Okay.
And I work really hard to try to get their head nodding up and down that this is worthwhile, and that we were going to do everything we could on their behalf. So it was always presented as sort of a value add. We also engaged though their staff, their teams on multiple levels. So we had practice administrators talking with practice administrators, and we connected at the practice administrator level, at the clinical staff level, at the referral coordinator level, at the whatever. We had people within our IPA structure whose job it was to connect. So it wasn't just dependent upon the provider at the top of the heap to make sure all this was happening.
Right.
So we had multiple means of engaging. We had, lunch meetings for managers or whatever. We had quarterly provider meetings. But by and large, I personally, and maybe this is just my personality, I personally found means to connect with these physicians face to face as much as I possibly could,
Okay.
to keep the face of the IPA in their consciousness, but to really begin to see me and the team that was working for me as a real asset. So then if I if I had to ask them to do something that was kind of, oh, you got to be kidding, the eye rolling requests, that you
Right.
get sometimes. We worked very hard to minimize those requests to make sure that they were on point. And as a matter of fact, we had the solution available to it, but this is what we need from you right now at this point in time.
Right.
I know this probably irritates the bejesus out of you, but you know what? This is what I need from you. So it was that constant of 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 being in their presence, being in their consciousness. Because after all, even in our more robust primary care practices, our contracted patients may have account for 15% of their practice.
Hmm.
And they have 85% with some other payer arrangement, who of course is also, tugging at their pant cuff,
Right.
or metaphorically speaking,
Right.
to do something for them. And I always wanted to be number one.
Yep.
Uh, and the other thing we did too is we tried to make all of our services as highest level we could, somewhat payer agnostic,
Hmm.
so that you're not thinking about, oh, this is an IPA patient, I need to behave differently, think differently
Right.
than I do for some other patient. And our case managers were really good. They know all the case managers for all the other health plans. So if you called with a problem you couldn't solve, they would know who to talk to. And so we really worked hard again to be an advocate for their practice, not just necessarily, another healthcare contract.
Right. Yeah, that makes sense. Well, great. So Scott, one sort of shifting gears a little bit. One area where I see enormous opportunity and real risk is in health-related social needs and behavioral health integration.
Mm.
You hear a lot about social determinants of health related social needs, and really regulators, payers, accrediting bodies, they're all pushing in this direction. The operational and compliance infrastructure often lags behind that aspiration. I think I've been
Mm.
part of a number of organizations that have tried to go down this route. It's not easy. You've worked in environments where these programs weren't just discussed but actually implemented, and I'd love to get your thoughts on this topic. It's really an important topic to systems, groups, payers, really all sort of service lines everywhere. So what have you seen work well when organizations try to address, and I'll just call it HRSN, or we call SDOH, whatever we want to call it, or
Right.
behavioral health at a network or a system level? What have you seen work well?
Oh, wow. Um, just from our IPA perspective, this came along. We actually hired a master's prepared therapist to become our behavioral health care manager.
Okay.
And we actually started credentialing behavioral health providers right into our network, even though, from a health plan perspective, we weren't delegated to pay for their services. They were carved out to us. We started building those relationships so that our care managers would have, dedicated behavioral health clinics that they could refer to,
Right.
because they were tied they were tied to us.
Okay.
And then also from a full service perspective, this is where there are community-based organizations starting as simply as a transportation company,
Right.
to make sure that people can get to their appointments or things like that. So we were able to we started building some of that in the context of the IPA. And we tried to get our physicians to say, in our clinics to say, hey, if you have a patient that has these kinds of needs and you're struggling to get services, just call your care manager.
Mm-hmm.
Right? Our care managers were distributed by practice or whatever. Call, fill in the blank. And so, again, it was really this sort of organic thing. Now, when I was, for a while, I was a Medicaid MCO, physician leader.
Right.
And the state of Washington and the Medicaid program actually has adopted what they're calling the no wrong door
Hmm.
kind of model of integration, where they want no, and in the state of Washington, behavioral health is carved up into mental health and SUD treatment.
Okay.
So in that model, the model was, whether you were entering through the medical portal, the primary care portal, the SUD portal, or the behavioral health portal, you would have ready access to the other two parts of the triangle.
Hmm.
So one of the things we did was I went around and we did a readiness assessment. We had a readiness assessment for primary care providers, and there are some published ones out there you can use. And we did the same thing with behavioral health. And so we used the results of those assessments to kind of help them think about what are the next steps. Because behavioral health integration could mean hiring a behavioral health person in your clinic.
Right.
But I've also seen that happen where there's no integration. They're just another provider off in a corner somewhere you know, seeing patients or clients.
Right.
The others could be, we had one practice I think about that had a big behavioral health clinic right across the street. Okay, from each other. Well, we don't
Mm-hmm.
have to hire anybody. We'll just put a care plan together, a shared care plan between us about how we're going to move people back and forth.
Right.
So I've seen lots and lots of versions of this, many of which have been wildly successful, and a lot of them have not been, because it's tough. There are different practices, but the state model has been pretty well adopted, and it's expanded outside of the Medicaid world. So what I would do personally in that model, I would just simply put health-related social needs as one of the nodes of that ecosystem.
Right.
And again, this is all about relationships, relationships, relationships. And I think from a legal standpoint or how you tie people together, it really a lot of this too is how you construct your network participation agreements to make it clear that there's a value prop for both parties by entering into this relationship together.
Yeah. So it's a great, and I was just going to ask you about that. And you kind of address it there. So when I think of this question, you could put it into two different buckets, right? There's the behavioral health piece, which there's certainly a clinical aspect to that. And I'm not saying there isn't a clinical aspect to HRSN or SDOH. There certainly is, and that's sort of what the common understanding is that is our whole health has more to do with uh, just many different components of our life than the symptoms we may be experiencing at the moment. And so that's where I think you just mentioned the relationships become such an important piece of this. And you're part of an IPA, or you're part of a system or a network that is trying to implement or integrate a behavioral health piece or an HRSM piece to their program. It can easily, well, first of all, it can create compliance liabilities potentially. It can also become an unfunded mandate, which is another separate issue.
Right.
It's a totally different issue, but ensuring that your example of having the behavioral health clinic across the street and having some sort of relationship with them, obviously that has to be structured in a certain way that meets the right compliance and legal framework. the community-based organizations. You may have some other partnerships, but part of this is trying to get the patients the assistance they need, whether it's behavioral health, whether it's mental health or food security or housing or whatever the case may be. I mean, any other thoughts in terms of trying to manage those compliance liabilities? I mean, you brought up a great one, which is ensuring that you got it on paper. Your network arrangements are such that they meet
Yeah.
whatever the applicable requirements are for that type of relationship.
I think, well, I say too, yeah, measurables, right?
Right.
What are the, I mean, I remember in some ACO work that I was doing where we were working with, a post-acute network of providers, whether they be, rehab
Mm-hmm.
facilities or skilled nursing facilities or the like. And we built quite an infrastructure to support that. I mean, we had steering committees, we had metrics,
Mm-hmm.
we had report cards, we had, clinical cross training. We had all kinds of things going on there to make sure that post acute network was meeting our requirements. And the same could be true around any sort of, community based organization. How quickly can you process a referral? What does your assessment look like? What's your engagement rate?
Right.
How, all these kind of things. So you can create some metrics in the context of whether you call it a quality committee or a joint operating committee, the JOC kind of model.
Mm-hmm.
There are a lot of ways you can bring those people in, but I think the real challenge in this is the risk of the baby with the bathwater.
Mm-hmm.
When the administrative and legal and compliance requirements become so big and people kind of lose sight of the fact that I'm not sure there's good juice for this squeeze, the
Right.
answer you'll get is never mind.
Right.
So again, I think this is where the aggregator has an opportunity and a responsibility to to really carefully manage the detailed stuff on behalf of the providers, but make sure that you've engaged the providers where you really need them to engage,
Sure.
and not try to overwhelm them with other with they would things they would consider minutia,
Right.
which you and I know could be fundamentally very important,
Right.
but just not very interesting.
Yep. Yeah. Very interesting. Excellent. Well, Scott, I'm going to leave you with this last topic here. It's really pertaining to the kind of the future or trends with respect to population health, the future of care delivery. And as a healthcare lawyer, one of my biggest concerns is that organizations sometimes mistake compliance for strategy. Reacting to rules. We talked a little bit about this earlier. Instead of designing systems that can absorb the inevitable change, population health, care coordination, network-based delivery models, all of which have their own, as you know, unique legal issues. But they're ultimately leadership questions. And when I talk with healthcare leaders, population health and care coordination, it comes up all the time. It usually followed by the phrase, "We know we need to do this better," and then followed by a deep sigh. But you've had a front row seat to how these models evolve and have evolved in the real world. So, what trends do you see that have the biggest implications for clinical leaders and
Uh-huh.
compliance-minded organizations?
You mean like the future, like you mean tomorrow?
Yeah,
Or is it
tomorrow,
right?
which may change the next day. I mean, I don't know.
Exactly.
What have you seen?
I think some ways you gotta have a little thick skin and you gotta be
Yeah,
flexible. Stuff just changes.
sure,
I mean, you think about, I'm not gonna talk about any, political things or whatnot too, but you can see the impact of how one administration thinks about things and another administration thinks about another, and
sure.
what's CMS thinking today and whatever. So the very thing you do today may be considered a compliance foul tomorrow. You just don't know.
Right.
So I think you have to have a mechanism for, a surveillance mechanism as a leader. You got to
Okay.
find a way to kind of keep track of what's going on out there, and you can do that formally. You can do that through there's like tons and tons of newsletters,
Mm-hmm.
of various kinds. There's take your lawyer to lunch, kind of things or whatever, anything
Sure.
along the way to
I'm
say,
all in on that. Hey,
there you
take a
go.
lawyer to lunch. Yeah, you got me. You got me.
All right, next time I'm in Denver, I'll mind.
Sounds good.
But see, that's number one is you just got to be vigilant because stuff changes so fast.
Right.
So you have to be aware. But when you think about other future trends, I mean, think about all it, and some of these have ethical things, which
Mm-hmm.
ultimately become, legal and compliant. So think about, I mean, where are we going to go as far as new drugs, new treatments, genetic intervention? Just reading a little while
Yeah.
ago about an AI-assisted robot that removed gallbladders successfully from 8 cadaveric pigs without
Hmm.
a human even being in the room.
Wow.
You think about some of those kind of Brave New World-ish things. I think we don't even know what artificial intelligence is going to do.
Right.
Certainly it's going to make us smarter in some ways, but I just read just this morning, as a matter of fact, that ChatGPT has launched ChatGPT Health
I saw that on the OpenAI platform. Right.
on the OpenAI platform, and you can feed your medical records into that, and you can feed bio data from your Apple Watch or whatever, and somehow it's supposed to help you manage. And what about privacy? And what's the role of what about the provider-patient
Yep.
relationship? Is this going to be a substitute, or is this supposed to be an augmentation to make me a smarter doctor
Sure.
and help me and my patients make better decisions than we would otherwise just on our own, so we don't forget about something? Or is it going to be, like example? I have like my daughter recently. She was having some issues and couldn't get into her primary care doctor. So she ultimately did some snooping around, went over to one of the labs, paid commercially to get a bunch of lab work done, and then calls me with the results. It's like, what do I do with this stuff? And I'm going, well, maybe there's a different way maybe there's a different way
Yeah.
um, of approaching that. But I think that's going to be something I don't even think we have a clue. And the technology, unfortunately, is maybe marching ahead faster than we can actually think about.
Sure.
And the other one is going to be, and I have a personal interest in, is global care.
Hmm.
When you start thinking about providing care across borders, not even just state borders, but worldwide. And I'm supporting a friend and colleague now who's actually building an international behavioral health network
Okay.
on a single platform of providers who can provide culturally and linguistically appropriate care anywhere in the world. So if you're an expat living in, some extreme part of the world and you want to see somebody from your culture and who speaks your language because you're struggling with your new environment, we're actually building a network, kind of like the super IPA of behavioral health
Hmm.
providers. Now, when you think about the fact that you now have to deal from a compliance perspective with the regulatory, what are the regulatory requirements in Germany compared to Brazil, compared to the US, compared to Australia.
Right.
But I think we're going to see more of this because technology just makes it way too easy.
The world's so
And
much
that's just about
smaller.
behavioral
Yeah.
health. Huh?
The world's
Yeah.
so much smaller. Yeah, I mean, it's an issue. So probably 8 questions came to my mind when you mentioned the global the global sort of cross country behavioral health platform. You've got just here in the United States, you've got federal law which doesn't cover everything. So you got telehealth platforms that are accessible in all 50 states. You're dealing with a combination of, for certain things, federal law, but also what are the laws in all 50 of those states? And a lot of times, is sticking with the most conservative or the most restrictive, and then, for consistency and efficiency purposes, applying that across the board. Not always, but sometimes it's an easy way to do it. Now, I'm just trying to think, like trying to comprehend what does that mean when, to your point, you've got patients in Germany or Canada or anywhere across the world. That's a really interesting dynamic I hadn't thought about.
Well, we can have an after conversation.
That's another podcast session.
Right.
Oh, that's great. That's great. Well, Scott, this has been great. Again, I really appreciate your time. It's been a great conversation. We've covered a lot of ground here. We've covered everything from physician leadership, IPAs, value-based care, clinically integrated networks, the very real work of integrating behavioral health, social needs into care delivery. In other words, all the parts of healthcare that look simple in a slide deck, that I'm sure we've made it sound very, very simple here and get very complicated about 5 minutes into real life. And what I really appreciate is how you've framed leadership as alignment, aligning clinicians, aligning incentives, governance, and purpose, not just checking boxes or building bigger org charts. And from where I sit as a healthcare lawyer, that kind of leadership doesn't just make systems work better. It tends to keep, you mentioned this before, people out of trouble, which everyone can agree, I think, is a win. So thanks for the insight, reminding us that when clinicians lead thoughtfully, healthcare actually gets closer to what it's supposed to be. So really appreciate your time and your insight and your expertise today.
Yep, you're very welcome, and thanks for the invitation.
Well, thank you, and thank you to all the listeners for joining me today on Health Law Pulse. Your participation and your listening is very much appreciated. I appreciate you tuning in. If you've enjoyed today's episode, please subscribe. Please leave a review if you liked it. We are on YouTube, Spotify, Apple Podcasts. You can also find links to these episodes on my website, which is at www.healthlawcouncil.com. We'll be back soon with more conversations at the intersection of healthcare law, technology, and leadership. Thank you very much. Take care.
Thank you for joining us today on the Health Law Pulse. This podcast has been brought to you by Health Law Council, LLC, a healthcare law firm you can rely on. For more information about the services offered by Health Law Council, LLC, visit www.healthlawcouncil.com, or you can email me at john@healthlawcouncil.com.